Without much ado, begin this much awaited lecture. Over to you, Dr. Desi. I'm sure everybody is very excited to hear from you and Dr. Marco's lecture. Thank you.
Thank you so much for that excellent introduction, Dr. Nia. Yes, thank you for the invitation as well. Dr. Marco travels around the world. I know he has a very busy schedule, but I think he will enjoy coming to Malaysia to give you a talk on the Edelweiss implant block. So just a very quick introduction with regards to the implant block. About 2 years ago, Edelweiss ventured out into the CAD/CAM systems, and we introduced the CAD/CAM blocks. And with a lot of pushing from Dr. Marco Tudts, we made the implant block because basically Dr. Marco Tudts is an implantologist and does a lot of restoration of those implants using our Edelweiss CAD/CAM blocks. The CAD/CAM blocks is a special block that fits onto a tie base and is compatible to many tie bases around the world, and can be used either through an immediate loading system or can be used at a later stage where you can put an abutment and then a crown over. But Dr. Marco Tudts will talk to you all about that later. So it is, as I said, it is our honor and privilege to have Dr. Marco Tudts with us today. He is an excellent clinician as well as an academic. He is involved in a lot of implant and restorative work at the university. So we're getting a bit of academic background as well as a hands-on clinical background. So without further ado, I know most of you are wanting to listen to Dr. Marco Tudts. So please, over to you, Dr. Marco Tudts, and warm welcome to you.
Thank you, Daisy. Thank you for inviting me. And I will first put my screens on that you have everything for the presentation, and that we can have a look this together. Check it out. There is share. And now we can go on sharing the screen. Okay, does everyone see the screen for the moment? You can see
all clear, Marco.
All clear? Okay, then we can go and start with the presentation for everyone. Okay, everyone asked me to talk today a little bit about the digital patient, because I will talk you through the story, how we came to this special block, which Daisy said just to us. And we will finish with the case which you see at the right side from the screen, a full rehabilitation in the upper and lower jaw is made totally with this block. The idea from guided implant surgery and digital CAD/CAM workflow, what's important to understand is if you want to go full digital, you need some very important things in your life or in your daily business. You want efficiency, you want accuracy, aesthetics, longevity, and simplicity. And that's what we brought together in the system from Edelweiss. A few things about myself and the office. The office is named Cosmident. Our slogan is Reveal Your Smile. You see some nice pictures from the area where we're operating every day. This is Leer. It's a little town south of Antwerp. For those who are wanting to visit us, you're more than welcome. It's a very beautiful town. It is called a little bit Little Bruges, for those who know Belgium as Bruges with the canals, which is the same town like that, but a little bit smaller. Here you see the office where we're operating every day. The inside of the office, like it is for the moment, with the Christmas atmosphere. Because if you were here today, you would see it like this. You're more than welcome. The great opportunity which I got is to work already many years together with, I call him my brother, Stefan. This my brother in crime, because we know each other already so many years, and we met each other a certain moment in a congress in Brazil. And there we start talking, and by sitting together as two clinicians, we tried always to push the barriers a little bit more. And that's what you see here. I'm doing surgery, Stefan is doing at the same day the treatment with the Edelweiss crowns. And we call it a little bit like Albert Einstein told us before, creativity is intelligence having fun. And having fun, we have all day long. Digital dentistry, where are we going? What can we do this nowadays? Yeah, you can nowadays, everyone knows this, I think, colleagues. You can do an intraoral scanning, you can take a CBCT, a face scan, and you can even go to 4D motion. And almost everything from every part, if you want, from dentistry is possible to treat nowadays. We can go from ortho treatment, we can go from prosthetic treatment, endodontic, perio, and radiology. My screen is not appearing anymore. Okay. Why it's not? Okay, now it's going back. Okay, there's the virtual patient. Nowadays, what we do in our office in a daily clinic is we do a CBCT scanning, we do an intraoral scanning, and we do a face scan. We match the 3 scans, if you want, together to get the thing of the patient. And then if you want to go yourself to the digital workflow, you have to dare and to share some things. And I want to share you what you have to do as a step to go into the digital workflow.
Why is it so hard to take the leap? To grit our teeth and step outside our comfort zone? There are moments in life when we feel uncertain, even though we're perfectly prepared. And we sometimes feel small when faced with big changes. Some decisions cannot be taken lightly. It can be tempting to give in to our fears. But aren't these the very moments that make us? Nothing beats the excitement of confronting a new challenge. Nothing is as rewarding as growth. And beginning the magic of a new chapter. Sarek, now is the time.
We're all little boys or little girls, and we always have to grow. And if you want to be better in what we're doing every day in our daily life, yeah, we have to dare, we have to jump, and sometimes, yeah, it's a little bit scary to jump. But if we don't jump, we never will reach the highest mountain. And that's the idea, what I brought you here. And I will talk to you, like I told today, about the clinical digital workflow. This is our lab, where we're working every day, because we have an own lab into the office, which is producing all the nice works, which you will see into my presentation. What do we do? What do we need if we want to go like we're working in the digital workflow? We need a milling machine, we need an intraoral scanner, and we need something like we use here, a Spitfire, that we can sinter. If we want to go by sintering process in a normal way, zirconium, we have to sinter. But what I will show you is, because this is time consuming, by the new blocks we made, that you don't need this sintering anymore, and that it's much faster, much easier to produce something repeatable and something very nice. Daily office workflow in our office is scanning, designing, send it through the lab, mill it and place it. That's a little bit the idea what we're working. We have 2 workflows. We have the office workflow and we have the in-lab workflow. Like I told you, we have an own lab. And the nice thing about the own lab is that they can work for me and do all the work from the patients who are in the office immediately. Here you see some of the blocks into the big machines. We can mill to 6 crowns or 6 restorations together in one session. In the clinical workflow, like we work daily, is we get in a patient like this who broke some teeth and who has some abrasion, some erosion, some old crown and bridge work, and we will restore it. This what we do is we do an intraoral scanning. We prep the preparations. Based on the preparations, we do a new scanning, and then we go to the 3D printed model. And based on this 3D printed model with the preparations inside, we make a try-in, if you want, like you see here, to see if the form is right, if we have enough space for our restorations, and finally we go to the definitive restorations, to place it into the mouth, like you see it here. And we always try to be in the highest level of aesthetics to get a nice result. Edelweiss, we have it. For those who are known with Edelweiss, we know that, or you have to know that Edelweiss has 2 big systems. You have Edelweiss Direct and Edelweiss Indirect, if you want. The Edelweiss Indirect system is based on the new blocks. There are 2 worlds, but the same result. And that's what I will show you here. In all the lower teeth, you will see this Edelweiss Direct, and 1 teeth we prepped for a indirect restoration. And once it's milled, the nice thing what's coming out of the block is that you see a very nice polished result, very shining, very thin margins, which we can place. This is the prototype block which we used at the beginning. It's now for the moment already available, but at the beginning, from when I did this test, we did a testing to see if it worked for everyone in the world. And these were the first results which we had. You see a very nice adaptation, very nice gloss. Not this, and you see almost no difference between the direct or the indirect restoration. We can go by very complex rehabilitations. That's what you see here. This is the intake patient coming into our office, and he wants to get a full rehabilitation for his jaw. He was a businessman who worked very hard, but he didn't take care very much about his teeth. And finally, we had to do a full digital workflow because he didn't have a lot of time. This what we did is we scanned this original case. Based on this scan, we did 3D models, and based on the 3D models we made before we did any preparation, all the designs, we call it wax-up smile design, based on the models. The great thing about this way to work is that we don't have to prep the preparations, because we simply want to see together with the patient which way we are going. And this is what we do, this unprepped restorations. Unprepped restorations were simply put onto the existing teeth of the patient, to look a little bit to the aesthetics, to the form, to the occlusion, and everything what we want. Once we agree about the results which we have here, we call a digital mock-up, made in a kind of PMA material. Then we go to the definitive restorations, and we can go to solitary try in this blocks. And the first thing what we do is to get a bite augmentation in a patient like this, because we want to train his muscles that he doesn't have ATM disclosure problems. That's the reason why we first take our primary restorations, we glue them simply into the mouth of the patient without any preparation, and we leave the patient going out of the office like you see here for at least 2 to 3 weeks. That's the way he's going out of the office. This we didn't prep at all. We simply did minimal invasive, this dentistry, if you want, simply to see the aesthetics with the patient, to see the function and the occlusion. Once the patient is coming back and he agreed, we take off everything, and in a normal way, we go by full zirconium or porcelain fused zirconium, if you want. The problem which I occurred, and that's the reason why I show you this case, is that if you want to go with full zirconium, in a big case like this, where you have to augment the occlusion for almost 8 millimeters, you have to take time, and then it takes you a long time in treating period to get this done, because otherwise, if you go immediately to zirconium, patient occurs several times malocclusion and pain in his ATM. So that's the reason why we go first with the temporary restorations, see if everything is going well with the patient. After everything is going well with the patient, we change them by what we call temporary zirconium restorations, which you see here in a few minutes. I will show you now. Here you see them. These are temporary zirconium restorations. We check once again the occlusions, and if everything is okay with the patient after a few weeks, we change them finally by the final restorations with porcelain on top. But this is taking the whole procedure, taking us a lot of time, like you can see. Okay, a very nice work. Every one of you is known by this kind of work. It's done everywhere in the world. We do it also, but it's taking us a lot of time. And because we are having a lot of patients coming in from everywhere in the world, we try to bring them something which is faster and giving them the same result. And that's the way why me and Stefan came up with the idea to make CAD/CAM blocks and a material which has both features of once had the composite, but on the other hand, also the zirconium. Yeah, but the good things, we only want to get the good things from both together in one block. And that's what we try to make. And this is there's the publication which we had done about this patient, which I showed you just. But now I want to go over to what you're waiting to see, the full digital workflow with the CAD/CAM blocks. This is the patient we do now everyday treatment. Patient coming in with abrasion, with anorexia. She is an anorexia patient, which you will see immediately. She has a lot of erosion, caused by the reflux she's having every day. If you want to treat this in a quick way, you need a material which is strong enough, a material which has a lot of aesthetic capacities and which is nice to follow up anyway, and is going to get a very nice result in a short notice time, if you like. This is what we did with this patient. You see it here. The old restorations, like you can see, are still there. These are Emax restorations, which are placed before in the premolars, and you see by the erosion, the wearing, that our own teeth are wearing out. And what we do in a case like this is we do an intraoral scanning to have the situation. Then we do a minimal invasive preparation. This only for this. We decided here to go for 2 full crown preps on the premolars, 14 and or 1.4 and 2.4. The reason is because we wanted to have a stop, because palatal she doesn't have enough from her own teeth anymore, and we want to get a stop so that we are sure that she doesn't break the restorations. And for the rest, we go for minimal invasive veneers, like you will see immediately. We do immediately after scanning, we do the design in the office. We do a smile design into the computers. This design is only for our own working workflow. It's not for the patient, but simply to see if the dimensions are right, if you are in the right position, if we like what we are going to mill. And then finally, we're going to make on the minimal invasive preparations their stage into the enamel. We will do the preps, the preparations with the milling units. And that's what you see here. Just like I told you, we will go for 2 premolar full contours, and the other teeth were simply veneers. Once we mill them, we put everything together in our office in all the milling machines. We have a lot of milling machines. And then you see here the Edelweiss block into the milling machine. And then you see how nicely that we can prep and how smoothly we can prep this preparations, if you want, and the restorations to get them out. Finally, you see in half an hour time, average half an hour time, it's taking average, in between 6 and 10 minutes for one restoration to mill. But the good thing about this way of working is that you get out the restorations immediately. You don't have to put them in a sintering or a glazing process. You can simply polish them with little brushes, and you get the highly gloss from these restorations, which we can use immediately into the mouth of your patient. To check the occlusion and the contact points, we put everything together on a model, because we're working here in a few hours. This we want to get it done very quickly. Then we place all the restoration into the mouth of the patient. Yeah, and the nice thing is, the more that the restorations are into the mouth of the patient, the more they get shiny and glazing by simply brushing with the toothbrush. And that's what you will see immediately. You see the 8 restorations, 2 premolar restorations, and then the canine to canine restorations on Edelweiss veneers. And this is the patient when she's coming back after 1 week to have a checkup. Yeah, and then we see the patient before and after treatment. Yeah, and this is only 2 hours. This treatment time, if you want. We need to understand the digital workflow before we can go in a surgical workflow, because this is going a step further. And this is the way we treat the surgical workflow in a digital way. Like I showed you before, we take always a CBCT scan, we take a face scan, we take an intraoral scan, and we merge everything together. These are the clinical intraoral pictures. And in this patient, we are missing the 1-2 and the 2-2. And we will replace them by implants and immediate loading on top of the implants. The way we do it is, like I told you before, we merge everything together. We take a CBCT, we take a face scan, we take an intraoral scan, merge everything together, do our planning in advance, make the guides in advance so that we can do a minimal invasive surgery. Yeah, here you see us doing the planning. We merge everything together so that we're sure that we get the nicest aesthetic result which we can have to obtain, so that we're sure that we know exactly where is the position of the implant and exactly the position of the crowns on top. Yeah. And finally, if we agree with what we prepared here, we keep everything, because this is what we need to place the implants and to place the definitive restorations. This finally, it's going out like you will see here, this more in detail. Yeah, we put everything, and that's important for getting the aesthetics. We put everything into the mouth of the patient. We do the face scan on top. We check occlusion. We check the aesthetics. Yeah, we place teeth into the mouth of the patient. You will see immediately. We check once again aesthetics, smile line, and everything we need, form, everything we need. And once we agree that we are sure that we want to go this way, yeah, we go in the surgical procedure. Okay, this is the patient, and then finally, you will see that we have the guide ready. The guide can be milled into the office. Once it's milled into the office, we can do the surgery. But the nice thing is that before we started the surgery, we made, based on our planning already, the digital files. We transferred digital files already on the model, yeah, in the digital files. And we made already in advance the definitive crowns, if you want, the Edelweiss CAD/CAM crowns, which we can screw in after we did the surgery. And that's what you see here. Just we did the surgery, immediately place the immediate loading crowns on top. Yeah, the lower picture is a polarized picture to check if the color is right, because of course the patient has a dehydration, then you see a difference in colors. If we want to get everything right, and finally, this after a few hours, if you see the patient back, you see it like this, a very healthy gum, and that's what we see every day. We very nice aesthetic results. Very healthy gum, because the gum is responding very well on the new blocks, because we have into the new blocks such a smooth structure that your gum is loving the new blocks which we're using. Here you see the patient before and after. Yeah, the way we work is, like I told you, we do a scanning, intraoral scanning. We do it with the CEREC prime scan. We go in milling, yeah, and we do, if we need, yeah, a speed firing, but with new blocks, yeah, we don't need it anymore. That's what we will show you all the time. Yeah, what can we do? We can do a lot of restoration types, yeah, inside. If you can choose about screw to retained restorations, yeah, the cement retained restorations, there's temporary restorations. You can go by anatomic restorations made on anatomical, this custom-made abutments. You can work on tie-based restorations, which exists on very different implant systems. Yeah, and that's then the way. The good thing about digital workflow is what you will see here. I made a summary to show you a little bit what is the difference. Yeah, if you go by the conventional workflow, you have a lot of steps to go through. Based on the digital workflow, excuse me, it's going a little bit too fast. I will go back that you can see it better. This based on the digital workflow, yeah, you can skip a lot of the definitive restoration steps. The only thing what we need is do a digital impression and put the definitive restoration finally. This you miss a lot of, or you can skip a lot of steps which you have to do in the analog conventional workflow. But when you want to go digital, you have to agree that you need a learning curve. A learning curve, yeah, to put everything together. This, what's important, if you have a CBCT, use it for doing your diagnosing and your planning. If you go in the direct immediate loading workflow in your office, we need surgery and we need temporization. And finally, you can go to the definitive restoration. This you can do in office, or you can send it out to your lab where you used to work with, and you can make the restorations based on an individual abutment if you like. And this is the way why we work. Yeah, this we do always with every patient for implantology. We do a CBCT scanning. We do an intraoral scanning, merge all the data files together. Yeah, based on this, we do a 3D planning in the software. Based on this, we mill a 3D printed guide, yeah, to do the surgery. We place the implant, yeah, and immediately on top of that, we place the Edelweiss CAD/CAM, this restoration, this implant restoration. The question is what we all as dentists want, yeah, what are our dental expectations? We want, of course, aesthetics. We want, if possible, speed and long-term results. We want accuracy. And we want this simplicity and peace of mind. Yeah, of course, because this is the most important if we go out of our office, that we don't want to get in patients who is ringing us all the time and saying, yeah, I have an issue with my restoration. What do we know about accuracy? This is the dental probe which every one of us is using every day. Yeah, and to give you an idea about accuracy, for us, yeah, till now, this accuracy is the thickness of this probe is 0.45 millimeter. Yeah, and we did a little comparison to check out if we do a conventional impression with an impregum, which is well known. We compared this by a direct digitalization, yeah, and at that moment from the study with a lava COS scan, if you want. And we did the same thing, but then doing the impression, pour out the model, this and digitalize the model to see the difference. And here you see very well that the direct digital impression is more accurate than both others. This, if we are going to check it out where we are, yeah, if you go analog, you have an overall marginal map which is bigger than if you go full digital. There is no doubt about anymore that digital impressions are better than analog impressions. That's anyway something that we have to know from the solitaire restorations, yeah. But what is the issue if you're going in a full arch span? Then we see some other results. There you have to know that we have a control group, and if you compare the control group with at that moment all the intraoral scanners which were available in our country, we put them all together. We saw that prime scan was far better than all the rest. Yeah, if you compare to all the rest about the accuracy, if you want. Yeah, and this is to make it visible, easy. You can see this: the more you're in the middle of the cross, yeah, the better result we got. And you see that most of them, just what we see is for us. What is acceptable, if you're in the green zone, you're acceptable. Everything what is out of the green zone is not acceptable. At that moment, it was a study, 2019, Yeah, there were not so much intraoral scanner which had very good results at that moment. There's a big issue to compare about full arch restorations and partial arch restoration, and that's what you see here in this investigation, which was done in 2017. You see this, if we take at that moment a few scanners, that most scanners for this partial restorations or solitary restorations are in the same line and do it very good. But you see a big, huge discrepancy between the different scanners if you go in a full cross-arch restoration. And that's what's also seen in a study done by Kim et al. In 2018, where we compare conventional by digital this impression. And in a new study, which is done only this 2020, yeah, you will see this. And what you have to understand about that, if you compare this, the new advices, is that what's important if you work digital, that you have to take the most advanced hardware, you have to update your software, and that both the combination of the newest hardware with the newest software will give you the most significant impact on accuracy. To resume a little bit, what you have to understand from digital devices nowadays is conventional impressions still are the lowest in deviation for full arch, but the newest scanners are pretty well in the same range. The latest software is important. The latest hardware is important. Yeah, the choice of your scan flex and the position are very important. Yeah, the scan flex have to be matched correctly in your software. If you you need the right software library, and that's the problem with a lot of distributors for the moment, because every implant system is using another scan flex. This, I hope that in time that people will get all one scan flex for all the restorations, because this is making it a little bit messy and a little bit more difficult for us to understand. And then last of all, this of what is that abutment level digital impressions are more accurate compared to implant level. Okay. How efficient are the scanners nowadays? Before we would say that digital dentistry is much better for everything except for time, because it was time consuming. Nowadays, it's not anymore. And nowadays, you don't need anymore to go for the analog or the conventional impression if you want. Yeah. Guided surgery. Yeah. What are the limitations about 2D guided surgery, which we did or still do a lot of time? Yeah. The limitations of free-handed mentally guided surgery is that we can, because we didn't have at that moment CBCT images, which you see here now. And if we go back and have a look to this, the surgery which we did before, yeah, in a closed flap, but not guided, if you want, then we see that a lot of the implants which we see on CBCT are, they're doing it very well, but they are not in the right position. This is a limitation of 2D guided surgery. Yeah, there is another situation like you see here on the screen that, yeah, if you don't do a flapless surgery, that you have an increased healing time, but the risk of having something missed is also more great. That's the reason why in a classic treatment approach, what's important, yeah, bone quality is important, yeah, grafting if you need it, sinus augmentation if you need it, yeah, a proper case selection is important, and selection of the patient population is also important, due to a study done in 2013. All patients, if you make a question to the patients, are you happy with the implant solutions which you got? Most patients, and this is a study done in our university, 2015, by the Bruin et al. Yeah, we see that most patients are very pleased with their implant restorations. Yeah, there is no discussion about the implant restoration. And most patients, they say that timing of implant placement doesn't affect their satisfaction. Yeah. Also, most patients doesn't express, or if they do express, a clear message to save natural teeth if possible. Yeah, and most important, most patients prefer a straightforward over complex surgery. This most patients, and that's important to understand, doesn't like to do big surgery although that the doctors mostly prefer to do this great big surgeries, but the patient doesn't like. How to come into the game of guided flapless surgery? What do you know of what do you need if you want to get into this arena? If you want, you need surgical skills, you need prosthetic skills, you need aesthetic skills, digital skills, dental technician skill, and you have to be empathic to understand what is the right choice from your patient for your patients. Of course, everyone knows of us that you need to know good anatomical structures. Yeah, you need at least to have a basic surgical training. You need to understand what you're going to do. Yeah, and you have to understand that if you go in a guided surgery protocol, that there is no point of return, there's no recovery surgery possible. That's the reason why, if we look to literature, we will see that the safety margin till now we still use in guided surgery is 1.5 to 2 millimeters. Yeah, because it's based on the quality of the CT data, the stability of the surgical guide, mechanical errors caused by the friction of the drill in the guide tubes, the angulation of your drills in the tubes, and the density of the bone. A few things to keep in mind is, even if you're going to do guided surgery, is always have a backup plan, because if you don't have a backup plan, yeah, and you have a failure, you can get this like you see on the picture with the track. Just be aware that you are the driver, you have the drill in your hand, and you have to know what you're doing. What do we need, or what do we want to need? We want a simplified treatment solutions. Yeah, this we need something which is cost effective, less invasive, and giving most patient satisfaction. There are some principles which I have to go a little bit over it before we can go in the total planning, yeah, which we do every day. These are the biological principles. What do we know from literature? If we're going to look which are the trigger for peri-implantitis, if you want, you can divide it in 3 big groups. Yeah, purely plaque induced is only 1/3 of the population. Prosthetic triggered, it means done by the prosthodontist of the dentist who is treating the patient. It's also 1/3 of the cases. And surgical triggered is 41%, but in general, you can say 1/3, 1/3, 1/3. This, what's important to understand here, that peri-implantitis, which is a big issue this nowadays, is triggered mostly by or the surgeon or by the dentist who is treating the patient, and not especially by the patient itself who has not a good oral hygiene. Yeah. What's also important to understand, if you want to go in a full digital workflow, you have to understand the principle of a Tudts, yeah, and compare it by an implant. Principles are the same. The only difference, or the big difference, is the biological contour concept, like we call it, yeah, like you see it here. This you have to take in advance, and that's very important that you know this at the moment from the implant level, that you need at least average 3 millimeters this before abutment, before your the abutment height, if you want, before you start with your crown, to get not a violence of the biological weight. And what did we see by doing a study also in our university? We saw that, yeah, this remodeling of the bone is everywhere in implantology. Is done in the first 6 months, if you want. And we did here a study to place one implant a little bit deeper than the other, put the abutment on it, and looks after 6 months. And after 6 months, we saw that that the implant which was placed a little bit deeper with a higher abutment, yeah, had less bone remodeling than the implant which was placed more crestal, if you want. Yeah, and after that period from 6 months, we will see that the bone will stay stable for the next years. Yeah, and what you saw just is, if you compare everything and you bring everything together, is normal. You see it here. The idea is, yeah, that your implant placement follows your soft tissue thickness. The simple idea is you need at least 3 or 4 millimeters. Yeah, this from the level of the implant and the thickness of the the gum, if you want. Yeah, this, and we say if your implant is placed equal with the bone, then you need at least 4 millimeters of gingival height. If you have only 3 millimeters of gingival height, it's preferable that you place your implant a little bit deeper. If you have only 2 millimeters, you place it 2 millimeters deeper. And if you have only 1 millimeter, this thin biotype, then you place your implant 3 millimeters. Because that's depending. If you place your implant crown too close to the implant level, then you lose, caused by the biological width, you lose anyway this bone, and that's what you don't want. Another thing, what we prefer not to do is to change all the time from abutment, to take off too much times the crown, because every time that you take off your crown and place it back, you disturb the healing process, yeah, and you get loss of bone once again. This is the way we place the implants. And like you see on all the pictures, we try to get all the bone around the implants without losing this implant bone, because we want a long-term stable result. Yeah. In the case which I show you immediately, we used a new implant, new for the area here. This we had already. This is the Astra implant, new prime taper from Astra. The idea about the Astra implant, where I worked also together with, is that we wanted to have the ideal situation from Astra EV, which has the good features in it, that it had lasting bone care, that it was efficient in handling, that it had good aesthetics, and that it had seamless workflow integration. But we wanted to do immediate loading, something which is more easily to get a higher torque, and that's what we got here together with the prime taper. And the way we work in the office is in the workflow. We will go through it now together. This is the first patient which we did with the Edelweiss, the block for the implantology. This was the trial case at that moment, which is also published and which you can find back onto the web site from Edelweiss if you want, and you can take it off there. You can have the video there, you can have the brochure there, you can find it there. This patient was called Tatiana. We did a digital planning based on the CPST intraoral scanning. Yeah, we had to remove on the 4-6 this a root. We did the immediate placement of the implant and did afterwards immediately loading of the implant by the immediate loading crown, in this case an Edelweiss CAD/CAM crown, which you will see here. And this is the case which we then did as first. And this was also, like Daisy told already before, the start of the new block, which we find out that we wanted to have. The best thing of this block, why would you choose for this block, is because the problem with what I saw a lot of time and see every day is that, especially with internal connection implants, and nowadays we're using a lot of internal connection implants, that if you put on top the internal connection implant, a tie base, or a custom-made abutment, and on top a full zirconium crown, that the zirconium is too hard, and that if you have a patient with abrasion and erosion, that you will grind on the zirconium. If you don't check every 6 months the occlusion, it's possible by grinding out his own teeth, like you see here also happening, that he is getting over-occlusion of the implant. And then you know that, or he will have an over-occlusion in the implant, which is causing peri-implantitis by over-occlusion, or he will break the screw in the implant, or he'll break the implant crown. But the zirconium crowns nowadays are so hard that they don't break anymore. The screws into the implant don't break anymore because we have an internal connection. And what I see a lot of times is that not the zirconium crown is breaking or the tie base with the internal connection is breaking, but that the implant itself is breaking. And you see it with a lot of systems. And that's the reason why we brought up the idea that we have to make something which is as good as zirconium, but not so hard as zirconium, which has the good features to give immediate loading, and which has the same hardness a little bit like this normal animal, if you want. And that's the block which we designed. and you can go in two phases, like we told already before, or you can go directly in a screw retained restoration, or you can go in a primary, this abutment restoration, and put on top the zirconium block, the crown. This is also, we call that the eye block. It's also available by Edelweiss for those who are interested. Yes, you can find it. This everything what we did in the case which I showed you, just this was described step by step. This you can find back the procedure step by step there. And here is another case which we did on that way. Yeah, we placed the implant. Yeah, based on the implant, yeah, you can go, and that's the way you can work in your daily office if you want. You can work in 3 different ways, workflows if you want. You can go, if for those who prefer, by the analog way. You can go by the digital way, and there are 2 ways of working in this case, because we used the Astra EV prime taper implant. We could go by Atlantis, or we could go by CEREC workflow. This is what you see here. Yeah, doing the digital scanning and the analog impressing at the left side. Yeah, based on that, we do the CEREC workflow, because this is the way we work every day. The CEREC workflow is very easy, because once you place the implant, you do an intraoral scanning with a special, this tie-based abutment if you want. Then the other way around is going by Atlantis, but then you have to send it out to a lab who is producing the restoration for you. Yeah, you can do both, like you see here, and finally you get both restorations very nice. These are all this Edelweiss CAD/CAM restorations which we did. This is Atlantis way workflow. The other way is the direct workflow in the office. Normally, and that's important that you have to understand, normally what do you do in a normal office? You do a scanning, you do a designing, you do a milling of your restoration. If you go by zirconium, by example, you have to sinter it, you have to finish it, and then you can only cement it. This takes you a lot of time. What we did is we compared a lot of restoration materials together. Like you see here, we have zirconium. We have Tessera is a new material which is comparable by IMAX. Yeah, we have the Edelweiss block on top. Yeah, and we have this zirconium-based material. And if you compare these materials, you will see that they all look the same. Even our Edelweiss block is looking very nice, like you see here. Here you see the Edelweiss block, and the Edelweiss block has this nice, this enamel translucency, has the dentin part, like you used to get it with zirconium. Now, next level, because this is the final part of the final 2 cases, I think, that I will present to you, to resume a little bit what we had to do in this very short time. A full rehabilitation. The way we do this full rehabilitations is, this is a patient which had orthodontic treatment. They had maxillofacial correction of this upper and the lower jaw. Yeah, and then we plan to do the implants. Yeah, and do a full rehabilitation in the upper and the lower jaw. Patient is coming to the office with the brackets in place. Yeah, we take everything off. Yeah, we do, based on the position, we do an intraoral scanning to do a 3D planning. That's what you will see immediately. Yeah, here you see the results after orthodontic treatment. And then we leave everything in place. We do, based on the CBCT and the intraoral scan, we do the placement of the implant crowns to have the right position, and to, based on this, to put the implant on the right position. Yeah, this we check occlusion parts, we check the depths about the nervus mandibularis, if you want. That's what you see here. We had not a lot of space, yeah, because we had the position of the nervus mandibularis, which was very high. This we had only a very thin space where we had to stay above. Based on these designs, we go first in this case, and that's what we did before, but in the last case, which I will present to you, you will see that we do everything together. We went at that moment in the classical way. Classical way of treatment is, restore the upper part, place the implants, and in last time, place the implant crowns later on. In this patient, we did because she asked to go for the full preparations, because she didn't like her teeth, and she did to get them restored finally in total new teeth, and that's the reason why we went in minimal. We kept into the animal with this patient, but we went a full contour crown, like we call it. That's what you see here. Did these preparations, did the intraoral scanning. Based on the intraoral scanning, we're going to design the crowns. This is what you see here in the software. We can adapt all the thickness, and with the Edelweiss crowns, you can go very minimal. That's the nice thing about the Edelweiss crowns. You can go to even 0.2. Yeah, just you can go really minimal to get a very nice aesthetic and functional result. Here are the Edelweiss blocks which we used there, and then we made the crowns. These are the crowns coming out. Once they're coming out, we can place them immediately into the mouth of the patient. This is a normal, like I call, 2 hours treatment. Just do the preparations, do the scanning, do the milling of the preparations at the CAD/CAM blocks. The restorations are coming out. They are only polishable. This is the only thing what you need to do is a 2-minute polishing by each restoration, and then you can place them. And that's what you see here. And finally, the end result with the patient upper, crowns done in Edelweiss. And you see this, if you could compare this with the normal zirconium crowns which we have, you don't see a difference in aesthetic result. And then finally, to close down and to give you what we did only a few weeks ago in November, all together here in Belgium, we did a masterclass, a 2-day masterclass, where the masterclass we planned this patient. This is the first day we did lecturing. The second day we did all what we lectured in a whole day. Today I have only 1 hour, yeah, but at that moment we lectured the whole day, and the day after we showed you the patient, and that's what I will show you now, the result of what we did at that moment. As the patient came in, we will do a full rehabilitation of the total upper jaw with on his own teeth crowns, Edelweiss crowns, and for the rest placing 4 implants, yeah, in a very difficult situation. You will see in there. And the lower jaw, we will also go for a full rehabilitation. Yeah, the only thing what we didn't do in this case today is the implant in the position 4-5, because this was still a healing site. Only 2 weeks ago there was done an extraction, this it was not ready to place the implant. That's the only reason why we didn't place it there, but we did full planning, upper jaw 4 implants, like I told you. And the tricky thing in this patient was left side it was okay, like right side it was okay. In the 1-6 position there was no issue, like you can see, bone enough to place the implant properly. But in the left side position 2-4, 2-5, and 2-6, we had an issue, a problem, because we had a very huge dip, like you see. This, we had a lack of bone. This, we wanted to go by an immediate loading. This, I have to solve this at the moment itself. That's what we will do. This, what we did is we did a proper planning, placed the implants, built up the bone around the implants, and did at that moment this intraoral scanning to do an immediate loading. But because we had such a big area of lacking of bone and build up of the bone, I choose at that moment to splint the 3 implant crowns together to be sure that they could integrate very nicely. Here you see the guides which we used. This we simply used at that moment a pilot guide to direct me in the right position. We did indeed, the patient came in, did always the same workflow, an intraoral scanning. Based on this intraoral scanning, yeah, of the situation of the patient, we made a CBCT scanning, place everything together. Finally, we placed this implant. You see here the 4 implants placed, upper 1-6, and then 2-4, 2-5, 2-6. Yeah. And finally, after placement of the implants, we did an intraoral scanning with the scan flex. Yeah, because the patient was there. That's what you have to understand. We did a 1-day treatment. Patient is there into the office, is still waiting to get his crowns. Because we now, for the moment, go to the laboratory and produce the definitive crowns. Yeah, and meanwhile, we are producing definitive crowns. Yeah, this is what you see here. This is the design of the definitive restoration, and like I told you, it goes by the lack of bone and the buildup of the bone. I had to do this. We choose at that moment to splint the crowns together, so that we can do them afterwards separate. This is what we did. Yeah, we printed the model. This, based on the model, we could make the restorations like you see here. They are all Edelweiss CAD/CAM restorations. Yeah, here you see the solitary implant crown for the 1/6, and you see the 3-unit implant bridge. If you want, there are 3 solitary implant crowns which are splintered together. Yeah, you see 1 inlay and 1 crown. And this is the final result of the patient. After this, we started this patient in the morning at 10 o'clock, and the evening he was finished. Total upper jaw done, total lower jaw done. Yeah. Fully immediate loading at the 2 side parts, and for the rest, definitive restorations in Edelweiss, all Edelweiss CAD/CAM blocks. And here you see the healing, the nicely healing about the gum. You don't have any inflammation. Yeah. And this everything is very healthy. Patient was very happy with the result. And finally, this is the X-ray of the result which we did. Yeah, the CBCT X-ray after this placing the implants and before we did the loading. Details here. You see the huge defect we had to restore, and you can also see this what I restored to the bone. This I had to augment a lot of bone to get it done. Yeah. But here is the result. And now I will let you see the whole procedure, which Stefan and me did at the same day.
Hello, this is the second day after very extensive treatment what I had. And I'm really, really surprised. The result is a wonder what Dr. Mark and Dr. Stefan fulfilled with the cooperation between Edelweiss and Cosmiland. I was included to the whole planning before, so I knew what's gonna happen with me. And of course, I was a little bit afraid about the full mouth rehabilitation, included 4 implants on one day. So that treatment that you fulfilled, it's really a wonder. Thank you very much.
Okay, and with that, I want to close. And like I always say, most smiles are started by another smile. I hope you enjoyed the lecture. I have to say, it's 1 hour is lecturing is very short to bring a lot of materials together, because like I told you before, normally we do this kind of lectures, yeah, with much more material, even in a total day, like Daisy knows. But anyway, I tried to give you an idea what we're doing in a daily office and what we could do with the new Edelweiss CAD/CAM blocks, not only for the dentists who are not using implants, because it's used for total rehabilitation, but also for implantology. Thank you. And I hand it over now, I think, to Daisy this for the Q&A answer.
Thank you so much, Marco. That was excellent. The more I listen to your lecture, the more I learn. It's amazing the amount of information that you can put in 1 hour. So thank you so much for that. Extremely informative. And I like the way you tied in and brought the Edelweiss CAD/CAM into your implant system and to your immediate loading. That seems to work quite well. And the fact that you mentioned that the zirconia starting to break the implants now, not just the screws. That's why we have this new Edelweiss eye block. So thank you so much for that lecture. We will now open the floor for some Q&A and discussion. For the moment, I have some questions that I'd like to ask. The first, Dr. Marcos, are these blocks milled wet or dry? Do you need certain bears?
Yes, the blocks you can choose anyway what you want. You can mill them if you want wet and dry, but I prefer to mill them wet, and that's what we do daily normally. Yeah,
yes.
I think it's better that you try to mill them wet, because if you drill them, if you want to do it in a dry way, you get a lot of front material sticking into your drills, and that's the reason why you prefer to do it with wet drilling. Yeah.
Yeah, absolutely. From the manufacturing side as well, Edelweiss recommends wet milling with that. Otherwise, your entire milling machine will be full of powder and dust all over. So wet milling will definitely get a better finish as well. And the other point I'd like to mention that this is, and Dr. Marco mentioned it, is once you mill it, you don't need additional firing or glazing. You simply need to polish it with your go-to brush or a woolen brush, and that's enough to give you a shine. You don't need to put additional paste or anything like that. So that's a big time saving and cost saving for you. The next question I have is, did you do a crown lengthening for the first patient?
And then I have to...
I think it's Tatiana, that was your first patient you showed. Did you do crown lengthening?
No, I didn't do a crown lengthening. I did with Tatiana, with the implant, I think. What was it? Is it a question about the implant case or another case?
No, the question just simply states, did you do crown lengthening for the first patient?
Yeah, I have to check. I will check to get, if I go back, if I go back to my first patient to have a check, what was the patient?
It was patient Tatiana was your first patient.
Yeah, there is. It's depending. Are they asking about the first case which I did the full bridge, or is it the first case which is it the full case? In the full case, we didn't do a crown lengthening. I don't know. Just
yeah, as I say, I've just got anonymous attendee,
yeah,
and so maybe if you could just repeat your question and maybe a little more specific, and Dr. Marco will answer that. So the next question is, doctor, for the first case, full mouth rehab,
Yeah.
How to determine how much vertical height can we increase? And can you explain in detail the workflow of producing the temporary PMMA?
Yeah, okay. That's easy one. This in a case like this, I think, Daisy, are they still, if I move my screens, are they still seeing the screen? Yes.
Moving, the slides are moving, yeah.
Okay, then I know about what I'm showing them. Okay, that's good. It's about this case. This, if you want to go from this situation, which we have a lot of abrasion erosion, and we want to go to the full rehab, like you see here, what we do there is I do always a smile design to start. And in the smile design, we check how much material we lost already from the teeth. And normally in a case like this, it's pretty easy to do that, because you see always some points where you see that the animal is still intact. If it's still not intact, we try to do a CAD/CAM design in the smile designs, and we add the material which we lost. It means, you know, a little bit average, that a front teeth, by example, average is 1 centimeter or 10 millimeter. If you measure that you have only this 8 millimeter, I add 2 more millimeters. If you have 6 millimeter, I add 4 millimeters. And this is primary when I start deciding for me how much I want to add from material. But in a case like this, like you see here, we add, and in a lot of cases like this, we do it a lot of time. And this will be another question which I saw already. We add easily 4 millimeter in the upper jaw and 4 millimeter in the lower jaw. It means that we go by a total amount of raising the bite, if you want, about 8 millimeter to 1 centimeter. And then I get a lot of we get, not only me alone, but also Stefan, get a lot of questions. Can you do this? Yes, you can do this. Yeah, but the first thing what you have to do, I didn't show it to you here, you have to train the muscles of the patient. Because if you do what we do a lot of time, do immediately a full rehabilitation in a case like this with hard material like zirconium, yeah, the patient for sure will get a lot of ATM problems. This is what we do in a case normally, or you go by a Michigan splint is called. This, you train the muscles of the patient for 4 months. And you try to get this. A Michigan splint is kind of splints with the patient is wearing 4 months, simply to train the muscles in the new bite height, if you want. And what we do in that way is, at the moment you take out the splint, the patient has to ask you after 1 minute or 2 minutes already, doctor, can I get back my splint, because it's more comfortable if I wear it. And then you're sure that you have the trained muscles, if you want, that you don't have ATM problems afterwards. The problem what I see in a lot of big cases like this is that a lot of doctors are going to restore immediately by a definitive material like zirconium. And then you get a lot of ATM problems, or if you don't get ATM problems, you get, before with the normal metal porcelain, you get breaking of your porcelain. With zirconium, like I told, because it's so hard, you won't get a breaking of the zirconium, but you get, of course, ATM problems. And there is, based on that, I see how are you going to produce the temporary PMMAs? Very simply, because what we do is we go in a digital wax up ideal situation. That's what you see here. This we can print immediately in a 3D printed model, and we can print this, what we call ideal situation, in PMMA material. And then I can glue it in onto, and that's what you see here, I can glue it in onto the non-prepped crowns with simple composites. That's the way we do it. And by glue it in by normal flowable composites, the patient can wear this for a few weeks if you want. And he can feel if it's comfortable for him, yes or no. And the good thing about that is also that if you see that he is grinding, because this is a PMMA material, he will grind on the PMMA material. And then you have to be clever enough that if he is coming back into your office, that before you start with producing your definitive restorations, definitive restorations, that you scan the patients with the PMA materials where you grind it on, once again, because you need to get this grinding places in your new material. If you don't do them, you have over contact spots and over occlusion, and this is what you don't want. But the main reason why I brought up a case like this is, if you want to do it in a proper way, like I did here, I had, first of all, to produce PMA restorations. Second, I had to produce temporary restorations, solitary on every teeth, if you want. Third, I went in what we call temporary zirconium restorations. And fourth, we went in the definitive zirconium restorations. I had to go by 4 restoration types before I could finish this case. And by the new material blocks which we have, we combine the very good results, and Daisy can tell you or show you if you want this for sure. The nice thing about the blocks is we combine the best parts of zirconium, porcelain, and composite together, and that's the reason why we don't need anymore all these steps.
Thank you, Dr. Marco. I have another question. Hi, doctor. For the last patient, why didn't you try to do veneer only instead of full crowns for all the anterior upper teeth? Won't it be risky to do the vital crowns? I take it that would be for Jack, is it?
Yeah, but Jack, it's the case from Jack here, yes.
Yeah, that was the last patient that you did. So why didn't you go for veneers for the upper anterior?
You could go in veneers for the upper anterior. That's another choice. It's not a bad choice. In this case, you could go for that. The only reason why we did it here is we wanted, because there was also big fillings in his teeth. If you go to the old restorations, you see that he had already a lot of big restorations. And the reason why we went for a full, we call it not a crown, we call it a full contour, is because we wanted to cover all the old restorations. That's the only reason why we did it. Yeah.
Yes, yeah, he had quite a bit of leaking margins in the palatal side as well. And so we opted for the full contour crowns, just that we know that he's done and we don't need to go back later and still do full contours. Yeah. Right, so in the meantime, Dr. Niad, if you have any questions as well, please feel free to ask.
Yes,
discussion from the group. So I have another question here. How do you do the occlusion planning for full mouth rehabilitation? I would imagine it was similar to the question that you answered earlier, but please feel free to go ahead again. How do you do the occlusion planning for full mouth rehabilitation?
Well, normally this, I think, Daisy, you want to ask me about how do we go if you augment the bite? Like I told you before, there are 2 ways that you can do it. The first way is, like I told before, the Michigan splint you can use and train the patient muscles in the height that you want. Then you have to, if you have the situation of a jaw, you have to put him in an articulator, and you put this splint like he's wearing it for a few weeks or months. Yeah, put it back also like this into articulation. Once it's done, you have the raised bite if you want, and you can add material whatever you want. That's one way. Then you're sure that because you checked it, that everything is right. The other way is what I showed you just, is going by or a temporary material. Yeah, what we did before, that's like PMA material. But nowadays, I don't go anymore with temporary materials like PMA. I go directly by Edelweiss, because anyway, if the patient is feeling this as too high, the material is strong enough to wear this, and it will wear out a little bit, yeah, in the parts where he finds the occlusion, and it's easy, and that's a good thing. If you check, because you have to check on a regular basis your patient in his occlusion spots. If you see that by checking the occlusion that he has too high occlusion spots on some parts, with the Edelweiss blocks, it's very easy to take away this over occlusion, to polish it very simply, and it's still the same material. If you do this with zirconium and you grind on the zirconium, you destroy your zirconium structure. That's the problem.
Right. Thank you. I have another question. The female patient where you did the anterior veneers and premolar crowns was done within 3 hours.
Yes.
Was there any crown lengthening procedures done on this patient?
No, there was none done. I will take it quick that you can have a look. It's here in the front. Here she is. Ever here. This, if you're looking back, this is this patient. Yeah. This, and I will take her in close up here. This is a smile line if you want. Yeah, you can argue if you want to do this crown lengthening, but then she gets even bigger, longer teeth, and she was already, you can see it here, she was by the anorexia already a very thin lady if you want. This with a long face, I don't want to give her the long teeth because aesthetic wise it's not it looks here like you see it, that's before I start with the restoration. It looks like she had already very long teeth there. This I don't want to give her even more longer teeth. This is what we did in a situation like this, and I will try to let you have an idea. Is like you see here. Here you see my preparations on the scanning. You see, I didn't do a crown lengthening. The only thing what I did, and that's what you will see immediately, this on the 11, if you want, 1. This I did a little bit a crown lengthening with a laser. I went inside the pocket to respect the biological width, if you want, because I want to get this lengthening of this tooth on the same level like the 2-1, if you want. And this is what we showed you here also in the perspective of the smile design. And finally, if you go to the definitive results, here you see it on the model that we did only a small crown lengthening on the 1-1, if you want, not on the other two, because these are the plaster models. If I would do a crown lengthening, you had seen it also here, but I didn't do it there. Only on the 1-1, we did it a little bit. And then we see these results. And if you're looking very well and very nicely, you will see here, yeah, still a little bit irritation of the gingiva margin, because this is immediately placed after 2 hours. And this reason is because I did a little small crown lengthening with the laser, a biolaser in this case, yeah, which I could use for reducing the bone level if you want. Okay.
Okay, that answers the question. I think that's Dr. Nia.
Yes, doctor. We have a few questions here. So firstly, actually, Dr. Marco, it was a phenomenal lecture. I'm sure it was an eye-opener to so many practitioners who do things the conventional way, and to know the possibilities that digital dentistry can have in just transforming every dentist's practice. So firstly, thank you for that. And we're so happy to collaborate with Edelweiss for such a wonderful lecture. So we have a few questions from the delegates that we have on our group here. So the first question is, how do you do face scan and what is the purpose?
Okay, with face scan, there is a few ways you can do it nowadays, but in the nearby future, there will be much more companies bringing the face scan on top if you want. And the good thing about the face scan is, like you see on a slide like this, that you can put everything together. There is a lot of things to say about face scans. First thing is, because for yourself, you will see immediately the result which you want to obtain or which you want to do for your patient, not only on a model base, not only on a CBCT base, but you see the face of the patient on top of it. And that's the good thing about that, is you have all the parameters together. This, you don't risk to have any mistakes anymore by getting crowns too long or in the wrong position, because you see the crowns already before you did the restoration into the face. In these cases, we did the face scan with the face scanner from Zirkonzaan. This is a company who is dividing. This is a special tool, if you want, which you can use to do a face scan. but also Planmeca has, and more companies have it, Planmeca has in their CBCT, in the high-level CBCTs, they have also the option to get a face scan inside. Just at that moment, you take a CBCT scanning, and there is a tool inside which is also making a scan of the face and which is mimicking the face of the patient over all the CBCT data. And last thing what I hear is that, but it's not for the moment. Perhaps in your countries it's already getting there, because what I heard that also some companies from Asia area are bringing some new face scanners on the market. This I'm very eager to see them, to test them, because this will be really the new tool if you want to have something into your office. Yeah, and it's working very easy, to be honest. It's like a normal camera where you go in front of the face of the patient, and then he can merge. The only thing what you need to have in this face scanner is that he can recognize some points where you can match the CBCT data to the face scan. But this is technology, yeah.
Yes, doctor. Actually, a follow-up of the question asked is, are the intraoral scanners that are used, can that be used for face scanning as well?
No, the intraoral scanners are not used for face scanner, no. Yeah, it's a separate tool if you want, which we use for that. No.
Yes.
In our office, it's like you see here on this picture, you see the CBCT, that's the axial CBCT from Dentsply. And there is also a tool available for doing the face scan. But Planmeca has it, yeah, and I'm pretty sure that also some other companies will, if they don't have it for the moment, will integrate it in the future in their new, but you don't have to buy an expensive CBCT with a face scan on top, because I'm pretty sure if you go to the new, if you will look in IDS, the new IDS coming up in March next year, where all the companies from everywhere in the world, I'm pretty sure that you will find a lot of companies presenting a face scanner. Because I think I can simply say, wait a few months and you will see them popping everywhere in the world. I'm pretty sure.
Thank you, doctor. So another question is, do you use the surgical guide until the implant placement or only for the pilot drill?
I use both. In the last case which you saw, I used only a pilot drill. The reason was because I had to augment the bone and I wanted to open the flap and to see where I had to augment the bone. But if I don't have to augment bone and I can go flapless, I use a fully guided implant placement through the guide. And but my time to talk about that, and Daisy knows this, was too short, because I can talk you a whole day about fully guided implant placement, because we developed as part of my another PhD, which I'm doing, this part, and a total new tool, if you want, to do a fully definitive immediate loading. And most people in the world for the moment are saying that they can do immediate loading, but everyone on the world is doing for the moment immediate loading with a temporary crown. Yeah, because they always say, and what they say is, you have to put a temporary crown, you have to put him out of occlusion. Well, we developed a system where you can go with a definitive crown. What we use there is also, in the case of Tatiana, the Edelweiss block. Yeah, because I'm pretty sure that this, I don't want to use in this kind of case, to be honest, yeah, zirconium crowns, because then you get over occlusion and you get a losing of your implant. This I use both indeed. Yes.
Correct. The next question is regarding partial surgical guide. How stable is it?
If it's based on, like we show you here, it's based on enough tooth are available, it's very stable. You don't have to worry about it. Yeah. If you have a nut, a guide is as stable as your precision of making it. This it depends a lot of things. One of the things is that your intraoral scanning has to be correct. Your CBCT data has to be correct. This both has to be merged correct, yeah, on each other. And then you have to be sure that you have enough space to get a stable guide. And the last phase, which is important, is the 3D printing of your guide. Yeah, this that you have the more the more space you leave between the guide and your teeth, which you will support the guide on, the more unstable it is. Dus I think you have to go as less space between the guide and your teeth. Dus the guide has really to fix into the position that he can't move while you're doing the drilling. That's important.
Yes. Thank you, doctor, for answering all these questions patiently. We just have one last question. How does the Edelweiss block react against normal tooth, normal crown, and an implant crown?
Okay. How does he react about normal tooth? Very well, because he has the same hardness, in wearing, if you want, like enamel. That's the reason why he acts very well on a normal tooth. About how does he react if you have an opposite zirconium crown? That's also clear, I think. The zirconium crown is harder than the Edelweiss block, and you will get out a little slightly wearing, not from the zirconium, but you will get it from the Edelweiss. Yeah, but that's the good thing, in my humble opinion, because if you have an implant like I showed you, and we see a lot of cases where we have to take out the implants because you have a fracture of the implant caused by the very hardness of the zirconium, and especially the full zirconium. This, if you have an Edelweiss crown opposited by an implant crown in zirconium, by example, the Edelweiss crown will wear out a little bit, but the good thing about the block is that even if it wears out, it stays very polished, because the more you polish him with your toothbrush and your toothpaste, or the more you polish with your own teeth, the more glaze he gets. That's a good thing.
Thank you, doctor. And somebody's asked us, when is your next lecture regarding the immediate loading of implants? We are pretty interested to attend it, doctor.
That's a good one.
That's a good one. We are planning for the moment, because we had, like Daisy told, I had a very huge program last year, this everywhere, we're now in planning to start over the next year with new master classes. To be honest, I give a lot of lectures. If you put on my name, you will see me everywhere on the world. What I'm planning also together with Daisy and with Stefan is to check what are the demands for the moment on the market. And like I hear already, Daisy, one demand, I think we have to take this with us and to check, and we can, if we have data, or we can give it to you, and then you can give it to the participants if you want. Or there's another solution, you can invite us and we come to Malaysia.
Yes, absolutely. That's a very good option. I'm sure everybody is going to be very excited for that. So we'll work on doing that in the near future soon.
Okay.
Yes.
We'll be happy to host you.
Yeah, that will be an excellent idea. As you spoke earlier on about the collaboration with the Excel in Malaysia and Cosmeden and Edelweiss, that will be a great idea, and we can work on that. And I think taking the immediate loading patients cases, and we can present that at Malaysia Congresses or some workshops that you want that we can attend. That will be an excellent idea. So let's look forward to a very good collaboration, and that will be excellent. So that's good news that there's some interest, or quite a bit of interest, regarding immediate loading. For me, and of course, Dr. Marco, as I said earlier on, is a father of the implant block, and no one knows it better than he does around the world. So it will be excellent. And I myself, because we started this project together, is very excited about the implant block. So it will be really a great opportunity to come to Malaysia, and we can present there, and we can talk about the implant block and immediate loading. So we're looking forward to that. There is one more question. How about the strength and staining after treatment with the Edelweiss system? Dr. Marco?
The strength is no problem at all. The only thing what I can say about that is once you have the chance, and I think you have to ask it perhaps at your local reps, is once you take an Edelweiss, not even a block, the block is very stable, but even if you take a normal Edelweiss facing, yeah, and you try the original, you try to put him on the table and to push him and to break him, you will see that you need a lot of force to break it. This is so, and the block is even more homogeneous, is more even harder. That's not an issue, the hardness. The staining, you can stain everything. Also, the Edelweiss block you can stain outside. The only problem what I have normally with staining is that the staining will wear out because it's done partially. This on the superficial structure, if you want. This what we do a lot of things is we stain inside. Yeah. And then if you place it, yeah, your staining will never wear out because you can really easily stain the block inside.
Yeah.
Like the gears.
Yeah, that's excellent. So any other points of discussion from your side, Dr. Nia, or from the participants? If there's anything else that you want to add on to the Q&A, please feel free to do so. Dr. Nia, is there anything that you would like to?
Well, actually, these were all the questions that we had, and Dr. Marco answered all of them patiently. But this is a very new thing for all of us over here, including me. It's something that we have to learn from, and this was a good start for us. But definitely, we need a lot of experience and training. And with the help of you, I think all of us can adopt it in our professional practice.
Yeah, that's with digital dentistry, and Marco said he travels around the world now lecturing, and it's certainly as caught on in the world, and this is the way to go in terms of your practice. So for those that are there already, to go on with Dr. Marco's expertise and to take on the further sort of expertise from his side to build up on your practice. And those that haven't started, this is a good time to start, because I think this is the future in dentistry. And with regards to the Edelweiss blocks as well, is biomimetic, we minimally invasive, and that's where the future is, and that's what ties in so closely with Dr. Marco's philosophy in Cosby Dent. So if there's no more questions, I'm sure Dr. Marco has got a waiting room full of patients. That's the beauty of Dr. Marco's lecture, is not just involved in university and just not giving lectures. His hands are wet all the time with patients. So all those cases that you see are personal experiences, and he tells it how it is. So it's not like sort of, flowering things or anything. It's his own experience. So that's what the beauty of Dr. Marco's lectures is, and that's why he's so popular around the world. So once again, thank you so much, Dr. Marco, for making the time. I know your time is precious, but providing once again, an excellent lecture. Dr. Nia, thank you so much. For me, it was a pleasure having you as a co-host, and best wishes to your group. I know that the group is growing, and all the success to your group with Excel. We look forward to a very good collaboration with Cosby Dent, with Excel and Edelweiss. That will be an excellent thing. We have a WhatsApp group, so please feel free to join, all the participants to join in this Edelweiss users group. And Dr. Marco is always putting cases there, and any questions you have, he will answer on the group. So it's a very busy group, lots of questions asked. Dr. Stefan also answers quite a bit. I'm there as well, so please feel free to join that group. And we have lots of social media interaction through our Facebook, Instagram, so please feel free to join, and we can make this digital community grow and see a success in our practices. So once again, thank you so much, Nia and Dr. Marco.
Thank you, Dr. DC. Thank you for being so cooperative, and your entire team, which helped us bring this forward. I'm sure we have a long way to go. We're very happy to collaborate with you.
I am pleased as well. Also in the backgrounds, we don't hear Nele, that's Dr. Marco's personal assistant. She's in the background, and I have Sway here as well, that's been working frantically. If one button's not working, another one not working. So they always chatting in the background, making sure that we have a successful webinar. So thanks to Sway and Nele as well. And in Malaysia, we have Hong. That's our sales director for the Far East. So please feel free to contact him. He's been putting this all together since last year. Has been working on this project. So please feel free to contact him. He is a very good personality, very outward, likes to have a nice, good friendship with all his clients and doctors. So very approachable person. So Hong is a man to get hold of if you need any advice or you need to get to us as well. So once again, thank you everyone for participating in this webinar. Once again, thank you, Marco and Dr. Nia, for your excellent contribution to this webinar. Right, so that's it. Any last closing statements, Dr. Marco and Nia, and then we can close down?
The only thing what I want to say is, first of all, I like your logo behind you, Nia. Very nice.
Thank you. I will convey it to the team.
Yeah, it's really nice. Yeah, this I like it very much. And Daisy knows if I'm saying things like this because I also like nice things. This I like it very nice. Yeah. That's a very good choice. And second thing what I want to say to all the participants is, yeah, even if you see, because it's a short notice, if you see a lot of things which you like, but you have to understand, like I'm telling you also in the story, yeah, if you want to go digital, you can do it. Yeah, this and a little bit like I always say is everyone can do it. You have to take time a little bit to learn it. But if you're willing, and I know that you are all people who are very curious to learn these things, but the nice thing is that your patient will love it even more than before, because patients love to get these things done. And like we had the testimonial of our patient, which we did. The nice thing, what you didn't see there, but what perhaps have nice to know for the participants is this patient, the evening when we finished the case, the full case, the full rehabilitation case, he drove home the whole night. And the day after, he went in the office to check up that, because I asked to check up that everything is okay. And at that moment, I didn't know this, but I got this nice video from him to say, yeah, everything is okay with me. I'm feeling very good. And this is after having such a very huge, big treatment, if you want, a whole day treatment. Yeah, he was still having there. But it's all, for sure, it has also something to do. And this is something for all the Malaysian and colleagues from that area, what they have to learn. We have some special thing in Belgium. We have duvel. For those who don't know duvel, you have to check it out. Yeah, because if you have duvel, everything works very nice.
Yes, excellent. Yeah, as Marco also mentioned earlier, that in 1 hour it's so difficult to put everything together and to have, but at least you have a taste of what is the possibilities in digital dentistry. Now we ran a 2-day workshop in Belgium about 2 or 3 weeks ago, and that was a patient that Marco is talking about, Jack. That's something that we can work towards and come to Malaysia with that. Where Dr. Marco, myself, and Stefan will do the lectures, and we'll do a live patient demonstration, and we can even bring our dental technician along, and we can do the full 2-day digital workflow, so that after 2 days you can feel comfortable to do that on your patients in your practice. So that's a possibility that you can look forward to as well. Maybe together with Nia and Excel Dentistry, we can collaborate something for the future for next year. So that's something we can look forward to.
Definitely. I think that will be very helpful to everybody attending, in a way that, digital dentistry, it also makes it easy for the operator, as well as the quality of patient care is also going to be enhanced. So it's like a win-win for both. So definitely that would be a very good course for us.
Yeah, absolutely. As I say that, we're bringing an expertise from a university background, clinical background, right there to you, so that you can't ask for better. I want to Sway just asked me to mention again that Dr. Nia has posted a link in the chat group. So please follow that or press on that link to join our groups. Is that correct? Yeah, yeah, to follow us. And then also you welcome to join, I think, Excel group as well, if you're part of the digital, and they are a growing organization as well. And I'm sure you will learn a lot from that group as well. So thank you once again, everyone. If there's no other closing statements, we shall end the webinar. Is that all fine?
Yes, doctor. It's been a pleasure. Thank you so much.
Thank you. Thank you, Dr. Marco. So that's all fine. Shall we close up?
Yes.
Thank you.
Bye, everyone.
Ciao. Ciao. Bye. Bye. Thank you, Marco. That was excellent.
My
Thoroughly.
pleasure.
Oh, that I sent a message to Nelly to say it just came out so the sound, everything just came out beautiful. The way you came across, it was just it ran like it was so smooth. Your lecture was excellent, really thoroughly enjoyable. So I think that's a good interest now we have. We can run a 2-day workshop in Kuala Lumpur maybe next year sometime. So it's something that we can do exactly